Hey, Herd, how you doing?
I'm great, Kyle.
Good. We got a lot going on. You and I decided to knowingly stay away from all the political stuff right now, right? I mean, there's just so much going on with the Trump administration changeover and who's coming and going in and out of significant positions. That's just something you and I are going to track and watch closely, right?
Yeah, I think we'll keep our eye on what plans may be out there. There'll be lots coming down the pike, so we'll cover that in future episodes.
Yeah, the first one, and I don't have a reference to a story, but it's a one that's just widely publicized right now, is around the United Healthcare CEO getting shot and killed just at basically coming out of a hotel, getting a coffee outside of a hotel in New York City. That's just terrible, right?
Yeah, absolutely terrible. I mean, he was on his way to an investor conference, and I think a lot of people have seen the video. And I think not only that was terrible, but a lot of the commentary that I've seen online and a lot of the just ugliness in terms of people, lack of humanness and lack of sympathy. I think we, regardless of what your opinions are on health insurance and how that works, that's not how we solve our problems and how we air our grievances in the country. And so it's a terrible tragedy and something that shouldn't be stood for at all, for anything in this country. It's not how we solve things.
No, I agree. I've seen it too, and on in my mind, those are two parallel tracks. The payers, using denials as a weapon. Uh, it and there are the sympathy goes to the patient at the other side of that denial and the battle that they have because they don't have the means to get the care that they need, and they're relying on the payers to provide that service. However, that's a parallel track. That is not a direct assassination decree for the CEO there. So anyway, it I understand the philosophical debate on denials of healthcare insurance companies, but not at all for just a murder to happen.
Yeah, it's a terrible thing, and again, not the way we should conduct ourselves
No.
or anything. And there's ways that we have avenues of change in this country, and that's not one of them. And
Yeah.
I think people should come out strongly about that.
Yeah. So beyond that, I mean, those are kind of the top headlines. A lot of the political change, and then this United Healthcare CEO. But then I have three more kind of big stories, and then I've got a few quick hitters. Is that okay with you?
Sounds great.
Okay. And a lot of these go in line with kind of our year end, recap of 23, and then we're about to do one for 24. But this next one, why systems are pumping billions of dollars into outpatient care. And we're seeing, and this is a modern healthcare story on December 2nd, that in particular, they're highlighting HCA and Tenet, but they could also be highlighting any number of health systems in our urban MSAs. This is something, Herd, you and I have been talking about for a long time, right?
Yeah, I think it's just, the way we've talked a lot about the way hospitals, health systems manage their revenue, and the cost shifting that occurs, and where profits are earned and profits are not earned uniformly across all service lines. And I think this is an example of that in action, where expansion into profitable service lines, expansion into areas that will help fund services that aren't as profitable. And a hospital has to manage that entire portfolio for the continuum of care. And as we've seen healthcare changing, as we've seen the way things are going, hospitals have to be very proactive in managing that, because one of the problems that we talk about rural health so much, a small rural health facility doesn't have that opportunity to manage the way a large health system does. And so I think it's just been interesting to see that in action over the years, and right in line with a lot of what we're talking about.
Yeah. No, it's right in line. The shift from in to out and the investment in it just makes a lot of sense. Now, that does say you've got a vacuum over here on the inpatient side. And what happens there? We've got hundreds and hundreds of billions of dollars invested in acute care inpatient facilities. And what does that mean for the life of those hospital beds? And I think that there's always going to be a need for some of them, many of them, but not all of them.
Yeah, I think more care, is shifting to outpatient. So you're seeing the providers, follow suit and provide and open up more sites of service for outpatient services. but at the same time, this providers, they still have inpatient services to provide. And I think a lot of the outpatient, profits that can be earned there help feed that so they can maintain the higher acuity, less profitable service lines. And again, it's about managing the whole continuum of care and trying to balance that portfolio. It's a complexity that, exists in the health system that most people don't understand. And most people don't see it on a day-to-day basis. But I think this is an example of where you see that in action.
Yeah. And I'll be quiet about this. One more point. There are dominoes that are falling as a result of that shift as well, because more of the care is born at the home, providing more of a demand on friends and family who may or may not be trained or competent, qualified, strong enough to help their loved one or friend to be cared for. And then, so it's, the home health is increasing, and frankly, so is the anxiety about taking care of those at home. So anyway, that burden doesn't go unnoticed, at least from the into outpatient. So moving on though, Hurt, the second one is really around the rural hospital margins are being protected through M&A. And so about half of the rural hospitals that were in the super high risk category have gone to medium risk if they find a host, a strategic host through M&A. And it can be for profit or not for profit, but as long as there's a strong urban core to kind of hub and spoke out to those rural hospitals to provide that, the capital, the technology, the expertise, the resources, all that, it's a lifeline to some of these rural hospitals. And we're seeing more and more of them get out of that super high financial risk of closure by through M&A and affiliations.
Yeah, this is an article. I think Fierce Healthcare had this article just about these affiliation strategies for rural health, and I think it really plays right in with the first news story. Right. Is the the difficulty that rural facilities have in making it on their own, and community has a rural facility, the care needs to occur, but they don't have these options to sort of manage a portfolio, and we have profits in one area to offset losses in others. They don't have that, and so I think this is a lifeline and a viable path forward for, well, let's join up and let's affiliate with some larger hospital, and then you can become a part of their portfolio. And again, it's kind of a larger capital pool to draw from, management expertise, and then frankly just being able to help be a part of managing that profitability. And so in aggregate, you can have a profitable, entity where pockets of it may be serving underserved areas that on its own can't make it. So I think it's a neat strategy to see and a nice story to see out there.
Yeah, me too. The final kind of big story for us is that, and this is out of Modern Healthcare on November 22nd. It says CMS releases 200 new Medicare residency slots. You and I have been talking about a resource deficit, namely doctors. We got doctors and nurses. We don't have enough of either one of them. And a lot of that is the choke point is training. And so CMS recognized that, put out, and I think that's even woefully short, but I don't know that we have the professors and the staff to train the new doctors, but 200 is a great start.
Yeah. I mean, I think one of the issues that we talk about almost every podcast, one is how you're going to pay for it. And then two is who's going to provide it. And so this helps try to solve some of the who's going to provide the service issue when we have provider shortages and we see those popping up. And so I think, this is a step in the right direction to at least solve who's going to provide the service.
Yeah. It's interesting too that once you get the medical students in, we're also seeing a shortage of residency spots for them. That we have a number, and it's a growing number, of new medical residents that are ready to go into the residency and fellowships that don't have a spot. There's kind of no chair for them after musical chair stops. So hopefully that'll be addressed as well. So those are the major stories. And now I've got just some quick hitters. And so the first one, our buddy Blake Madden at Hospitology put this in around 340B, and I thought it was a giggler, but I couldn't have agreed more. And it's saying that 340B is the most misunderstood healthcare program out there. there are a lot that do not misunderstand it at all and are capitalizing on it in a big way. We're seeing that right now, especially with some of the oncology drugs, with the cost of that, and they're flexing to try to make the most of that. But 340B is an immensely complex program. Any thoughts there, Herb?
Yeah, I mean it's a program that's been in the courts for so long in terms of just the way it gets funded and the way people access it, and I feel like it's been in the news for at least 5 years going, and just in terms of the way it's reimbursed and what it is. And so yeah, I believe I like the misunderstood healthcare program in history. It's obviously misunderstood because so much of it has been adjudicated through the courts the last several years.
Yeah.
And I think it's one where it's it's a great intent program, but exactly who accesses it and how it gets accessed and what reimbursement looks like under it, I think it's just kind of been seen as almost a place for people to find to find benefit, but and maybe it hasn't had the best track record of being exactly clear on what it's supposed to do. I don't know. It certainly been a part of a lot of the work that we've done over the last few years, especially anything involving oncology or infusion work.
Right. The next big hitter is frankly just a sad one, and it's kind of going down the path of Medicare Advantage programs gone wrong. And this one is from the Wall Street Journal, and it talks about how insurers collected billions from Medicare for veterans who cost them almost nothing. And so these are value-based care programs which are attributing veteran lives to them, and they're collecting premium dollars for them. But those veterans are going to the VA to get care. They are not going to the Medicare Advantage provider to do that. However, the MA provider is collecting those premiums, and frankly, so is the VA. So that doesn't make sense at all.
Yeah, it's just another story of the inefficiency in healthcare, and just the way the financial transactions within healthcare. It's too complex in so many ways, and there's so many ways to either game the system intentionally or unintentionally run into something like this, and so I think it just speaks to the complexity of healthcare, the way we finance it, and it just doesn't. It's a system that doesn't have the normal market signals that would help drive wouldn't allow these types of things to occur. And so how you get through that mix and how you try to reduce that noise and reduce that inefficiency, I think that's a job. Hopefully we'll see with the Trump administration and see what happens there, but there's certainly a lot of work to be done so stories like this don't happen.
Yeah. Bad story. Another bad story coming up, and this is kind of a Norman Rockwell moment for me, Heard. And it's the nearly 30% of U.S. drugstores have closed in 1 decade. And, when I think of the drugstores, it's not the soda fountain where you go and grab a milkshake. These are kind of the local drugstores. And 3 out of 10 have closed over the last 10 years. That's amazing, right? And what do you think that's attributed to? Is that the big boxes? Is that what is that? Or
I'm sure consolidation. You have Walmart's, Targets. Just thinking about all the big boxes, but then also just consolidation within pharmacies and drugstores. Right. Walgreens and CVS. I don't know their market share, but it has to be extremely high.
Yeah.
And so just, we've all kind of witnessed it.
Right.
There's a few, I think the ones that are making it on their own, you see a lot of compounding pharmacies and maybe smaller independents. Compounding seems to be a way they're carving it out and making it. But I think it's just kind of the same consolidation trend that we've seen with all types of retail, not just with drugstores, but with retail across the spectrum. So just a continuation of that same story.
Yeah. This next one is interesting. Biden proposes Medicare and Medicaid cover anti-obesity drugs. That's a tricky one, more ethical for the American people. The obesity crisis that we're experiencing right now, you hate to say it's brought on by ourselves, but we are making choices to become 2 of 3 of us are obese. And what would be the return on investment? I guess if you put that formula out there to say, Well, if those 2 out of 3 people are now taking Ozempic or whatever the drug is, and they're of right size and of right health, then that's going to take the hundreds of billions of dollars off of the utilization spectrum to this healthy lifestyle, right? But
Yeah,
that's a real ethical dilemma in my
yeah,
mind.
possibly. I mean, it could be one. It's try to keep people from getting sick as opposed to treating them after they're sick.
Yeah.
So it's possible. I think the long term uses of these drugs. I think they have a ton of promise. But I think right now it's still very early, and we'll see if that early promise pays off.
No, that's right. That's right. The next quick hitter is just that 44% of adults in the U.S. are uninsured or underinsured. I thought 44, that's almost like 1 in 2 is uninsured or underinsured. That's just sad, right?
Yeah, and this one surprised me. I think just with the Affordable Care Act and with the promises of that, and trying to plug those holes as far as uninsured or underinsured, this was a surprising stat. The fact that we're still there.
Well, and it goes back to our podcast with Andrew on frictionless healthcare and some of the generational differences of there's a couple of generations maybe behind you and me that are saying, I'm pretty healthy. I probably can get away with that. That's a lot of money for me to spend. Why would I spend it if I don't have to? And I feel pretty good.
Yeah, I think we see a lot of that. And that's always been present. And so it's a matter of how do you get people to buy into the system early? And I think it'll help everyone more later on. But that's certainly interesting. And what I'd be curious is what portion of that 44% is by choice, and what portion is because we've had inflation and now they're trying to figure out how to spend limited resources because their grocery bill is a lot higher than it used to be. So I think that's
gas, rent, whatever else. Yeah, it's all high now. So I'm just making educated choices on what I am and not going to spend on.
Yeah.
The last story is around hospital price transparency continuing to drop. That's a little surprising too, because there are all these things out there that CMS said, well, I'm going to charge you $1 billion a day. It's not that, but the penalties if you don't come in. Well, I think hospitals are watching, right, Herd, and they're just like, no, they're not really doing that. So I'm not going to do that because that's competitive information. I need to keep that all to myself.
Yeah, this was another interesting one. I think when the price transparency for hospitals came out, a few years ago, we had low compliance rate, and then compliance kind of crept up, and they increased penalties. But now I think there's hospitals are seeing that maybe they aren't enforcing those penalties quite as much, and it's just sort of a calculated effort. The other side of it, and we've been doing a lot of work with the data that's published by the insurance companies. So the insurance companies now have to publish price transparency data, and so you're seeing a lot of the same information now published on that side. I think compliance rate's fairly high there. Haven't seen that. And it's almost more of a one-stop shop where you can see, rates for lots of providers from one insurance carrier. So I'm wondering if that has anything to do with it as well. As that came online, the pressure for them to post is less. So, but certainly, I think we're baby stepping our way towards what this looks like, and it's going to continue to evolve over the next few years.
Yeah.
And this is something, with the Trump administration, the initial price transparency was really passed and really pushed by the Trump administration. First one. This is a bipartisan agreement here, and so I think also we'll see what happens in the second, and we'll see if that continues to grow and that enforcement continues to get higher.
So that's our news roundup, and we will see you guys soon. Take care.